I started, as I said, 25 years ago looking after people with HIV, and I have to say that at that time, the conditions in the healthcare facilities in the federal system in Ontario were primitive. I used to do a talk called The Third World in Our Midst because these healthcare standards were very much third world. We had some very ugly experiences early on. HIV in 1983, 84, when we first saw a case in the prisons here, was very much like Ebola. People did not know much about it. There was a lot of ignorance. There was a lot of fear. This was going to be the major plague that was going to sweep us all away. And so anybody who appeared to have AIDS was regarded as a pariah. We didn't have initially any good HIV tests, so what we did was respond to people who got sick. And it was some time before we actually got a test that will enable us to confirm that diagnosis. But we had some very difficult experiences in terms of people not wanting to look after patients in prison, with dying prisoners essentially being abandoned. There was no effective palliative care. And the healthcare system simply wasn't up to looking after patients who became acutely sick. And at that time, and over the next few years, I got in some face-to-face confrontations with correctional services which re-echo to this day, and the administration still regard me with some suspicion. By the mid to late 1990s, things had changed a lot. We had already had some 1 and 2 drug therapies in the early 90s, and it became apparent that compliance was going to be a major issue. It's not only a major issue for the patients, but a major issue for the prison system. They were not used to making sure that everybody got their tablets 3 times a day, which was what we were expecting people to get. And this was a big issue. And it was a big issue for a number of reasons. First of all, the system wasn't used to keeping up to date with supplying the pills. And secondly, prisoners did not want to take pills in the middle of the day when they were away from the cell. So a 3 times a day regime, which was what many of the early regimes were, simply didn't work. People didn't take at least one of their doses of tablets a day. In 1996, we reached one of our watershed points when the protease inhibitors came in, and it became apparent at that time that the new therapies were remarkably effective but would not work if people missed doses. And it was thought that all that it required was missing a day's dosage of your protease inhibitors, and you were liable to get resistant organisms. And this proved to be an enormous problem. That first of all, the regimes were complicated, they were relatively toxic, and the prison system really wasn't up to administering this. And we would find patients who hadn't had their medication for 3 or 4 days because the system had run out on a Friday and didn't get around to ordering them again until Monday, and the patient didn't get them till Tuesday. And when you've told the guy he's got to take his tablets 3 times a day or he's going to die, and then the system doesn't provide them, that's a major problem. The real dramatic change in care came, as I think Janice pointed out, with the provision of infectious disease nurse in each healthcare center. This has made an enormous difference. We now have the ability to deliver care properly. Patients are monitored properly. And the other thing that's happened is we have simplification of medication. So we can now give pills once a day. The patient can take that medication in the privacy of his or her cell, and nobody knows they're on pills. Whereas before, they were away at least in the middle of the day and had to carry the pills with them and take them if they were going to take them in the middle of the day, and that was just a major disadvantage. We still have a lot of problems with treatment. The HIV pill treatment is not a problem. It works very well. 90% of the people on medication have viral suppression, which is as good or better than they would have on the street. So there are a few people who simply can't take medications, whatever you do, and it's going to be difficult to do much about them. But we have other healthcare problems. Healthcare tends to get compartmentalized in the prisons. So one of the problems we have, if somebody has peripheral neuropathy, which is very painful, there are a number of drugs which are involved, which are sort of cascade of increasing treatment which you use, and we start by giving them tricyclic antidepressant at night. I cannot prescribe that in the prison. The prison doctor cannot prescribe that in the prison. The prisoner has to go and see a psychiatrist. So first of all, here's a barrier. The prisoners do not like going to see psychiatrists because that's a label. So eventually I get my patient seen by the psychiatrist who says, this patient's not depressed, I'm not going to prescribe an antidepressant. Comes back, so we're back at square one. This is what I call in the system, you can't get there from here. And there are a number of examples of that I could produce, but that's one of the more blatant ones. Another drug that we would like to use with the people with neuropathy is gabapentin, but we can't use that because that's a drug to which people become addicted. So there's a big barrier to actually using a medication which is a really important component of looking after peripheral neuropathy. Discharge planning has been a horrible problem, which is beginning to get a lot better, but still is a problem. Family docs in the community don't want to look after drug addicts who've been in prison. And quite often people will go back to their previous physician and be told that they're not going to look after them anymore. Patients who go out on morphine to control their drug habit will find themselves attending a clinic or a physician who will not prescribe morphine. And it's my experience, and there's a lot of experience, documented experience, that if you don't look after the drug addiction, you cannot look after the HIV. And so these patients default. And that's one reason for maximal default when they come out of prison. Just a reference to a couple of studies that we did. In 1994, we looked at Joyceville Penitentiary to see what there was in the way of HIV there, and we got a figure of 1%. But we also asked a question at the same time. We asked a number of questions which we did not link to the blood samples, but we asked how many people had used intravenous drugs whilst in prison, not necessarily in that prison, but whilst in prison. And the figure was 12%. We repeated the same prison, not the same people, obviously, in 1998, which time the prevalence of HIV was 2%, but we asked the same question, and this time we linked it to the blood samples and linked a lot of other questions to the blood samples, but this time 25% of people said they had injected whilst in prison. So that figure had doubled in 4 years. And one of the contributors to that, we think, was in 1994, the prisons introduced spot urine testing. They could pull a guy out of the yard, make him pass a urine sample, and test it for drugs, and which meant that smoking marijuana really didn't work anymore because it hangs around in the urine for days and days. And so people had to make a decision either to stop smoking marijuana or to change to something more exciting. And clearly a number of people had done that. More recently, we have seen some interesting things in the prison. The number of patients is falling. The 39 that you've heard of in the Eastern region of correctional services is the lowest number we've had in years. So we're seeing less people. Are there people in there who are simply not telling us? Yes, we think there are. When we did both our studies, half of the people that we picked up we did not know about. The other half were attending the hospital HIV clinics. So 50% hadn't come forward. Some of those knew they had HIV but thought they could make it through the sentence without exposing themselves to the sort of prejudice and risk that went on. The other interesting change in demographic we've seen in the prisons is 5 years ago, 95% of the patients with HIV were co-infected with hepatitis C. That number has now dropped below 50%, which tells us that we're looking at least half our population has shifted. And what we're seeing is a lot of people who are being incarcerated because they had sex with people and did not tell them their HIV status. And we've got people serving periods of imprisonment from 5 to 25 years for doing that, depending on what happened to the people they infected. And so we're looking at a shifting demographic within the prison. And these are an interesting group because the drug addicts who we've seen, many of them have a long experience of imprisonment. They've been in the provincial system several times. They may have been in the federal system before. This new population of people who've never been in prison. This is the first time they've tripped over the courts and they get a long prison sentence. So it's their first time in the federal system, and that's really pretty bruising for a lot of people. And so the sort of mental problems we see are actually enhanced in this group. And I want to close by talking just a little bit about harm reduction. Harm reduction involves education, and that education is supplied to peer groups, and peer groups or peer leaders are supposed to take groups and educate them. There's a lot of paperwork shoved around the prisons telling people how to avoid getting infected through sex, through injection. Bleach is provided. It's worth noting that bleach does not kill hepatitis C. It's not only is there no evidence that it does, there's some evidence that it doesn't. So I would like to close with a quotation from Dr. Linda Panaro, who is currently the advisor, public health advisor to Correctional Services Canada. And she said many years ago in a talk which I was present, education without the means of implementation is immoral. And I would like to underline that.